Thank you, Amber. It's a great pleasure to be here. With Heather Ross and Sir Megdi and everybody here. It's a great honor to be back. I was here once before, and thank you very much for the invitation. It's nice to be here. So today I'm going to talk about echocardiography in the diagnosis and prognosis of patients with heart failure. And the objectives are to understand two-dimensional, 2D, and Doppler variables that are used to help in the diagnosis of heart failure. And just to echo what Amr said, echo supports the heart failure diagnosis. It remains a clinical diagnosis in which you incorporate history, physical exam, lab markers, X-ray, and echo or other modalities to make that diagnosis. Describe the importance, secondly, of filling pressure estimation by Doppler, both on the left side and right side of the heart, which we find clinically extremely useful. And then I'm going to talk a little bit about the prognostic variables that we can get from echocardiography that helps determine outcome in patients. So let's go straight to the ACC recommendations. So the American College of Cardiology, along with many other organizations, came up with these appropriateness criteria. And there was a very nice document that you may want to look at, the appropriate utilization of cardiovascular imaging in heart failure. And their sense was that echocardiography with Doppler, they gave the highest recommendation as the initial non-invasive test in patients with suspected or known heart failure. And some of the advantages which I'm sure you're familiar with echocardiography, it is available in almost all centers that see patients. There's no ionizing radiation being ultrasound technique. It's non-invasive. It doesn't hurt the patient. And very importantly, it gives you real-time imaging. And whether it's Doppler or 2D, it gives you an instantaneous estimation of heart function and filling pressures, of course, which can change with therapy or other things, but that's very important. These results can be used to guide therapy. Also, it's very, very useful in the early detection of preclinical disease. Studies have shown that echocardiographic information, when done accurately, can help general practitioners and general internists in being more accurate in their diagnosis of heart failure rather than just using clinical variables alone. And it has been very useful in identifying patients with heart failure with preserved ejection fraction. And just a side note on that, we know people always ask me, well, why do the heart failure studies and preserved EF not show any effect of drugs? Is because we're finding out, and you'll hear more about this in other venues, of course, that a lot of these patients don't have heart failure. So if a patient has a normal ejection fraction and short of breath, doesn't mean they have heart failure. They could have a pulmonary embolus, obesity, COPD, obstructive sleep apnea, a whole bunch of things, okay? So it's very important to really have heart failure when you have preserved EF, and echo is very useful for that, as is N-terminal proBNP or BNP. So what are the variables? So let's talk about two-dimensional first. So when we think of echo, there's a two-dimensional data, and I know Dr. Sharif is probably well familiar with this and been teaching this. So there's a two-dimensional data, and there's the Doppler data. So in respect of two-dimensional data, left ventricular size is incredibly important, and we like to use volumes, but dimension can be used as well. And LV mass is very important, whether it's concentric or eccentric hypertrophy. Ejection fraction remains the single most important measure, I would say, that we use in echo for heart failure. But certainly if you have a preserved ejection fraction, you can't have heart failure. So there are other variables we use. Left atrial volume index, right ventricular function. Don't forget the RV. RV dysfunction is a very important correlate of exertional dyspnea and other problems. So it's very important to quantitatively assess RV function. And the teaching that, well, echo is no good for the RV, I would say that if you do echo well with new techniques, you can get a reasonably good estimate of RV size and function. Speckle tracking, so we use the two-dimensional integrated backscatter characteristics of the myocardium to assess strain, which is deformation of the myocardium, and I'll show you how we can use that. Now, Doppler basically is the transmission of ultrasound, where it reflects off a moving object, and the shift in the frequency of the Doppler is used to calculate velocity, speed, and direction of that object. So whether that object is a red blood cell with blood flow, we can estimate regurgitation, transmitral inflow, filling pressures, right-sided pressures, or even tissue Doppler imaging when we flip the wall filter so we measure the velocity of the myocardium is very helpful. Now just a comment here. Doppler is very important whether you have preserved or depressed EF. Why? Many patients, and I'm sure Dr. Amr and Dr. Ross see these patients, as you do as well, can have a cardiomyopathy, EF 20%. Just because your EF is 20%, if you come into the emergency department with shortness of breath, doesn't necessarily mean you're decompensated heart failure. That patient can have a pulmonary embolus, can have pneumonia, can have COPD exacerbation, many other things. So we find Doppler extremely important in making sure that someone with a known cardiomyopathy actually has decompensation, rather than having a non-cardiac cause of dyspnea, which of course can occur like in anyone else, and probably some of them more often than in patient without cardiomyopathy. Likewise, because you have a preserved ejection fraction does not mean you don't have heart failure. So the Doppler information that gives information on flow is exceedingly important in that regard. Having said that, ejection fraction is massively important. It remains, on multivariate analysis, one of the most powerful independent predictors of outcome in patients with heart failure. And if someone has an EF less than 50%, then certainly LV dysfunction correlates with symptoms and signs of heart failure and mortality, but there are other measures that need to be considered. So let's look at these images here. Okay, and so this is the parasternal long axis view. The ultrasound probe is just to the left of the sternum between the second and third rib interspace. This is the RV, this is the LV mitral valve, left atrium. This is the short axis view, parasternal. This is the right ventricle. And just a little tip, folks. The parasternal views are very good for RV size and function because the probe is very close to the RV. LV, this is a two-chamber view here, inferior anterior walls. This is the inferior septum, the anterolateral wall. So what do you guys think the ejection fraction is here? What do you think? Who thinks it's normal, greater than 50? Put up your hand. Nobody. Who thinks it's mildly depressed, 41 to 50? Okay. Who thinks it's moderately depressed? All right. And who thinks it's severely depressed, less than 30? Okay. So this ejection fraction was calculated at 34%. The inferior wall is akinetic, and basically there's an ischemic cardiomyopathy. So the ASC EACVI, European Association of Cardiovascular Imaging, formerly called the European Society of Echocardiography, recommends that we quantitate ejection fraction either by Simpson's biplane view, which is shown in this slide, or by three-dimensional echocardiography, which does not make assumptions in LV geometry and is not prone to foreshortening of the ventricle, which is a problem in both scanning and interpretation of echo. In this example, so the ejection fraction 34%, we trace the end diastolic volume 275 ml by Simpson's method, modified Simpson's method, and then the LV end systolic volume of 180 ml. The difference is the stroke volume, LV end diastolic volume minus LV systolic volume, and the stroke volume divided into the denominator of LV end diastolic volume gives you 34%. Okay, let's switch now another two-dimensional variable, LV hypertrophy. When I see this, I'm automatically thinking, can this patient have heart failure preserved EF? Why? Because a hypertrophied ventricle has impaired relaxation. In the limit of that, it may even have increased LV stiffness, whereby the pressure volume loop is shifted upward and left. And so when the LV receives a certain volume, there's a disproportionate rise in pressure, and that can produce LA hypertension, reflect back into pulmonary venous hypertension, and give you pulmonary edema. So the substrate of the myocardium, this ejection fraction is normal. It's actually probably hyperdynamic. It's in the high 60s to low 70%. But this patient has LV hypertrophy. So that structure is important because it creates the possibility of someone with the right afterload and preload to have diastolic heart failure. So that's very important. Oops. Sorry about that. Another one is LA volume. So left atrial volume has been called the barometer of chronic left atrial pressure, which is true. However, this image on the left, this patient has atrial fibrillation. So this patient has an LA, so we recommend, as stated in the American Society of Echo Guidelines, to do biplane left atrial volume in the 4 and 2 chamber view, either by the area length method or modified Simpsons. And the LA volume is then divided into the body surface area to give you an index. So this LA volume is massive, and you notice it's bigger. So another rule of thumb, if the LA volume is bigger than the end diastolic volume of the LV, you have a problem. So a normal LV end diastolic volume in a normal individual is what, 110, 120 ml? So in this individual, the LA volume is clearly bigger than this rather smallish hypertrophied ventricle. You automatically know it's big. However, this patient's an AF, so it's hard to know if there's elevated LA pressure. However, you can see the LA interatrial septum bulging to the left, so there's probably a concomitant occurrence in this patient of elevated LA pressure, but the dilation is also contributed by the atrial fibrillation. In the example on the right, this patient has an LA volume of 137 ml, 74 ml per meter squared, severely dilated. This patient has no atrial fibrillation. You can see the sinus rhythm in the tracing underneath. So this patient has an enlarged LA in the setting of sinus rhythm, and one can think of elevated left atrial pressures in that setting. I want you to be aware that the ASE and EACVIs come up with new chamber quantification guidelines. And it's very nice because those in the imaging field, and some of those imaging field, as well as the heart failure field, is always known that even when patients have a normal EF, there can not only be diastolic dysfunction, there can be contractile dysfunction, systolic dysfunction in the setting of preserved EF, as reflected, as epitomized by diseases such as hypertrophic cardiomyopathy, amyloidosis, other diseases, Gaucher's disease. So if you do strain in those myocardial segments, you'll see depressed systolic deformation. So we've always thought that EF is a very gross measure of systolic function. And appropriately, the guidelines have now changed. So for a man, normal ejection fraction is 52% and above, not 50. So they've changed the cutoffs. Mildly depressed is 41 to 51, moderate 30 to 40, abnormal less than 30. So these are the new guidelines, and I encourage you to look these up. They've been published a few months ago. LA volume cutoffs have also changed. Now 34 ml per meter squared is upper limit of normal, 35 to 41 is mild, 42 to 48 is moderate, and greater than 40 is severe. These are new, and they should be looked at in respect of how you acquire and interpret in your local lab. For females, the lower limit of ejection fraction is 54% now. And this is consonant with my clinical interpretation. I read an echo when someone has LVH and the EF's 51, their tissue Doppler systolic velocity S prime is low, their global systolic longitudinal strain is low. I know there's systolic dysfunction, so to call the EF at 51 normal, I think doesn't tell the whole story. So appropriately, the cutoff, lower limit of normal, 54% for women. That's very important. Likewise, the LA volume cutoffs are identical as they are for men in the new guidelines. So why is diastolic function important? So we talked about 2D variables. Let's shift now to Doppler variables. Well, as I mentioned before, filling pressures are critically important. But one caveat, Doppler is an instantaneous measure. So if Amr admits a patient with heart failure, decompensated heart, orders an echo. The echo is done 4 days later. Amr has started the patient IV nitro, given them IV Lasix drip, brought down their preload, started ACE inhibitor, brought down their afterload, and now they are near euvolemic. If I do the echocardiogram at that point, the filling pressures may be normal. That doesn't mean they don't have heart failure. It means that there have been changes in the hemodynamic milieu such that their volume status has markedly changed. So these are instantaneous. Likewise, when I do an echo and I say there's evidence of high filling pressure to preserved EF, patient goes for a cath 2 days later, the patient's been NPO, they're dry, they're dehydrated, they're vasodilated with fentanyl, and they cross the aortic valve and they find an EDP of 14. They say the patient doesn't have heart failure. That's not necessarily true. So it's very important to understand that these Doppler measures are instantaneous and they change rapidly, and that must be taken in context. So I'm not going to go through the whole cardiac cycle with you, but however, the phases of relaxation, the impaired relaxation, which is usually with LV hypertrophy from hypertension, that can promote increased filling pressures. but it's really the LV stiffness. So the tangent at it's basically the end, the relationship at the end diastolic pressure volume relationship. If it's shifted up, that gives you increased LV stiffness, such that for a smaller volume, you get a disproportionate rise in pressure, is really the fundamental physiologic property that gives one elevated filling pressures. And this is a nice article that was done by J.O. And J.O. is probably one of, I'm with him, the Diastolic writing guidelines for the next ASC Diastolic guidelines. He's probably one of the people, if not the person, I think, that understands physiology in respect of filling pressures and echo the most that I've ever met in the world. Having said that, they've done a lot of good work at the Mayo Clinic, and one thing we do understand is that pseudonormal filling, so grade 2 diastolic dysfunction, is marked by a decreased E prime, so you've impaired relaxation, in the setting of LV hypertrophy and elevated filling pressure. So this is this leftward upward shift of the pressure volume relationship. However, normal, you basically have, yes, a high E wave, but that's caused by rapid diastolic suction, which is shown by a high E prime in the tissue Doppler early diastolic velocity, E prime. And a normal relaxation velocity in the lateral wall is greater than 10, and the septum is greater than 8 for an adult. In restrictive filling, and one will notice that as diastolic dysfunction gets worse, your E prime A prime ratio becomes lower, reflects the E-A ratio becoming higher. So this is, in a setting of severely impaired relaxation, very high filling pressures. So mitral deceleration time, therefore, which is a time it takes from the peak E wave velocity down to the baseline. So it's actually, if you can look at the early diastolic filling, so the E wave is a peak instantaneous gradient between the LA and the LV as the mitral valve first opens. And then at the time it takes for that E wave to go to the baseline, sometimes it doesn't if there's continued LV pressure elevation throughout what's supposed to be diastasis. But the time to decelerate is really the time it takes for the LA and LV pressures to equilibrate. So if you have very high resting LV pressure and left atrial hypertension, when the mitral valve opens, there's a high peak difference that rapidly equilibrates the higher the resting LV diastolic pressure is. That's what gives you a short deceleration time. That relationship is tighter if you have depressed EF. If you don't have depressed EF, it's not as tight. That's because there are normals mixed in here. People have normal diastolic function. It's a classic restrictive filling pattern, very high E wave, 1.77. The A wave is 0.72. The EA ratio is 2.5, so anything greater than 1.5 makes you start to think of restriction, and a very rapid deceleration time of 121 milliseconds. Anything less than 150 milliseconds is consistent with restrictive filling, and that patient had a wedge pressure of 28 mmHg, so millimeters of mercury. Pulmonary venous flow is very important. If we think about it, you can forget all the memorizing patterns. Think of it this way. The pulmonary veins empty into the left atrium. So if I have a very lusotropic, so a very hyper-relaxing ventricle, what happens is the LV has such suction, and in fact, the early diastolic pressures, because of intrathoracic pressure being negative, are negative. So what happens is in early diastole, when the mitral valve opens, you have a continuous circuit between the LV through the mitral valve to the LA to the pulmonary veins, and you suck blood through the pulmonary veins into the LA into the LV. So you actually have a high diastolic wave in the pulmonary veins. As you have impaired relaxation but normal filling pressures, you lose that suction, such that when the mitral valve is closed during ventricular systole, your S wave is higher, and then you have lower filling during diastole, D wave, because of impaired relaxation. However, you then get a pseudo-normal pattern in the pulmonary veins. When you have very high mean LA pressure, the pulmonary veins cannot empty into the LA when the mitral valve is closed during ventricular systole, so you have systolic blunting. Then you get a rush of blood flushing out the pulmonary veins through the LA to the LV when the mitral valve opens, so a high D wave. So pseudonormalization also happens in the pulmonary veins. And to take it to a more advanced level, LV end diastolic pressure is different than mean LA pressure. LV end diastolic pressure is estimated from the difference between the mitral A wave and the pulmonary venous atrial reversal wave. Why? When the atrium contracts in end diastole, if it is meeting with a high LV end diastolic pressure, blood will regurgitate back into the pulmonary veins at a higher velocity for longer than going antegrade across the mitral valve into the ventricle because of high end diastolic pressure. So a difference in the atrial reversal wave in the pulmonary vein from the mitral A wave greater than 30 milliseconds is reflective of end diastolic pressure elevation. Why do I mention that? Another cath lab scenario. They put a catheter across an 88-year-old woman's aortic valve into the LV. The LV diastolic pressure, end diastolic pressure is 22. They say you have heart failure. But the mean LA pressure, the mean LV resting pressure in diastole can be 8 or 9. So especially in hypertrophied ventricles, there's often a disconnect between end diastolic pressure and mean LV pressure, and it's the mean LV pressure which, in the absence of mitral obstructive disease, is the best reflector of mean LA pressure. So in the absence of doing a transatrial puncture and getting a direct LA pressure, the best estimate is mean LV pressure, not end diastolic pressure. That's why I mentioned that. So that's pulmonary venous flow. Here's an example. Someone with impaired relaxation, normal mean LA pressure. Now they may have high end diastolic pressure, but the pulmonary venous S wave is higher than the D wave. If you think about it, if I had high mean LA pressure when the mitral valve is closed, that would prevent pulmonary venous emptying and give me systolic blunting and a high D wave. So think of it that way. So tissue Doppler, why do we care? Tissue Doppler helps us interpret normal from pseudonormal. So if I have rapid diastolic suction, like in a 15-year-old, I'm going to get a high E wave on the mitral inflow, right? But that is caused by a high E prime sucking the blood in, so a hyperlusotropic ventricle. On the other hand, if I have a high E wave in mitral inflow, but depressed LV relaxation by a low E prime, this E prime is about 4 or 5, that means it's a high LA pressure driving, if you will, the high E wave, and that's what we use. And you also notice a diastasis or L wave here, where you have continued atrioventricular antegrade flow across the mitral valve when you should have equilibration of pressures. That's where the word diastasis comes from. So the initial studies that was done by one of my mentors at Baylor, Sharif Naga, they found a very close correlation between E over E prime, or E over E sub A is the old name, and pulmonary capillary wedge pressure. However, work by others, including Steve Oman, have shown that there is quite a gray scale, a gray zone rather. So if your E over E prime is 15 or more in depressed EF, you have elevated filling pressures. If it's less than 8, they're normal. But there's a big gray zone in the middle in which we have to bring in pulmonary venous indices, left atrial volume, right ventricular systolic pressure, pulmonary artery pressure, etc. So when you look at the progression of diastolic function, it's grades 2 and more that really are reflective of elevated filling pressure, of also an increase in clinical events. And I know this is being recorded, so you can get these slides at a later date. You don't need to memorize them. So here's a nice example, a patient with a normal ejection fraction, completely normal. The E wave velocity is about 100 meters per second. The A wave velocity is 160. Well, the E is less than the A, right? They have to have normal filling pressures. Well, that's actually incorrect. So this is called a grade 1A diastolic dysfunction, which was first coined at the Mayo Clinic. And if you look at the E prime here, is very low. It's only 5 centimeters per second in the septum. So the E 100 divided by E prime is 20. So this is an example of elevated filling pressure. So the E being less than the A is simply a reflection of underlying impaired relaxation, but the patient has elevated LA pressure. The BNP was up, and the wedge pressure was appropriately elevated. On the other hand, here's an example of a patient obviously with a cardiomyopathy. So they come in short of breath, they must have heart failure, right? Well, not necessarily. The E wave here is only 50. The E wave is much lower than the A wave. The E over E prime, being 6, is 8. The BMP was 278, which can be very standard for someone such a cardiomyopathy, and the wedge was only 12. So here's an example of someone who has a cardiomyopathy, but it doesn't necessarily mean they always have high filling pressure. They need a certain preload to get them to the optimal point of the Frank-Starling curve. And so if their filling pressure is 6, they're going to be very hypotensive, but they're not necessarily always in heart failure. So let's quickly talk about Speckle tracking. Speckle tracking is an ultrasound analysis that uses integrated backscatter to measure movement of specific grayscale characteristics of the myocardium and follows them through space and time. By that way, independent of Doppler shift, we can measure deformation of regions of myocardium. That's all it is. So strain is a measurement of deformation, and strain rate is the speed or the time with which that deformation takes place. Okay? So by convention, strain, it's called Lagrangian strain, is basically the shorter length minus the long length, which is L naught, over the long length. So the long length is your beginning length. L naught is where you begin. L is the length after contraction of that myocardial segment, the difference of which divided by the original length is the strain, and therefore it's negative, because you start with the resting length. That's why it's negative. Okay, let's talk about an example, and I'll probably stop after the example because in case there are any questions, to allow time for others as well. So this is a case. This is a 51-year-old African-American male. Actually, he's not African-American. He was born in Africa, and he's been in Canada for 20 years. He has a history of high blood pressure. He presents to us with increasing fatigue and dyspnea. He was on no medications. He was a non-drinker, and he smoked cigarettes. On exam, his heart rate was 99 and regular. His blood pressure was 230 over 130. His respiratory rate at rest was 26 per minute, and he looked like he was having some difficulty. His JVP was 12 centimeters above the angle of Louis. He had a loud summation gallop on his examination. His chest was actually clear, and he had mild peripheral edema. So this is his transthoracic echocardiogram. This is a parasternal long axis view. So what do you see here? Yeah, so his EF is down. But remember, don't forget the RV. The parasternal views are excellent for the RV. He also has a lot of LV hypertrophy, okay, and a big atrium. And there's a small pericardial effusion here. Okay, he's got mild aortic insufficiency here. He's got some mitral regurgitation here. We need to assess more images. So this is his parasternal short axis. What do you notice here that's something we didn't see as well in the parasternal long? What about his septum? Yeah, it's flat. And why is his septum flat? Yeah, he's pulmonary hypertension. Very good. So automatically we know in systole, the LV is flattened because the RV systolic pressure is competing, if you will, with the LV systolic pressure. Here's an apical four-chamber view. Here's a left ventricle, mitral valve, left atrium, right atrium, tricuspid valve, right ventricle. So the RV function is certainly depressed. Certainly depressed. So is LV function. Mitral regurgitation was moderate. He's moderate functional mitral regurgitation. I mean, he certainly has a lot of afterload. Systolic pressure was 230. So let's look at the Doppler. So his E wave is 1.1 meters per second. His E prime in the lateral wall is 6. So his E over E prime is certainly elevated. It's about 20. The septum E prime is 0.7. It's probably a bit overmeasured. Look at his TR velocity. His TR gradient is 73. Remember I said his JVP was 12 above the angle of Louis. Add 5, that's 17 centers of water. That's about 13 millimeters of mercury. So we add 13 to 73. We have 86 millimeters of mercury. So you can say severe pulmonary hypertension, but it's actually not 2/3 of systemic. So it's probably more in the moderate range. Okay. So his TR is only mild. His IVC, quite dilated, but there's some collapse of respiration, so giving it 12, according to the new guidelines, is appropriate, and we clinically estimated 13. Okay. So the summary of the echo findings, severe left ventricular hypertrophy, agree? He has, his EF was calculated at 31%, so moderately severe. Marked elevation of LV filling pressure, moderate functional MR, and moderate to severe pulmonary hypertension. So that was done in February 2013, if you notice the date. He was treated with Lasix, Ramipril, and Bisoprolol. Over several months, he felt much better. He lost 12 kilos of fluid, and he's a thin man. On follow-up, when I saw him, his blood pressure was 140 over 92 millimeters of mercury. His JVP was only 2 centimeters above the angle of Louis, and his echo was repeated 7 months later. Okay, so his EF is clearly better. Still has LVH. Look at his RV. His RV is better. Look at the LA. The LA is shrunk. The LA is not a fixed structure. It responds to changes in LA pressure unless you're on the end stage of the LA disease process in which you have a lot of fibrosis. So MR is gone. AI is there. He's got a bit of dilation of the aortic root because of chronic hypertension. Parasternal long. What do you know? Parasternal short. What has changed? What's the main thing that has changed? Septum. Whoever said septum hit it right on the head. His septum, or RV pressure, is down. You see? So septum is now round. Why? Because the RV pressure in systole is not competing with the LV systolic pressure. Very good. Apical 4. His LA is much smaller. MR is gone. Look at his filling pressure. His E is very low. His A is high. His E over E prime is 9. Okay? Look at his TR velocity. It went from 73 to 16, even 20, if it's a bit underestimated. Doesn't matter. So his pulmonary hypertension, gone. Just from basically preload and afterload management. That's all. Okay? His IVC, this is only 1 beat, so it doesn't show the respiratory. So here's a 3D echocardiogram of this guy at follow-up, obviously. Good ejection fraction. This is using 3D to get a multi-plane view. And this is very good for wall motion abnormalities and septal abnormality. So it gives you 12 cuts from the base of the heart at the mitral valve level all the way up to the pap muscles to the LV apex. Okay, and his ejection fraction is obviously normal. However, we can derive more. So this is, actually this is a 3D ejection fraction, and it shows the difference between end diastole 130 ml and systole 65 ml. So the difference is 60 divided by 130, so his ejection fraction was 54%. We can also measure three-dimensional strain. So it takes a 3D speckle map of the left ventricle and gives us a global longitudinal strain. And his global longitudinal strain is negative 12 or 13% here. And remember, normal is more negative than negative 18. So the other thing that three-dimensional imaging allows us to do is we get global circumferential strain. So longitudinal strain is the deformation up and down. Circumferential strain is rotational strain. And we know that the LV, when it contracts, yes, the length shortens, but it also twists towards a centroid. So there's a circumferential rotation there. And his circumferential strain is abnormal. It should be more negative than negative 20. But the one thing that three-dimensional imaging allows us to do is to get area strain, which is actually a combination between longitudinal and circumferential. And his area strain was negative 26, and negative 40 or less is normal. So I pose this question to you. Given that his ejection fraction is 54%, he has grade 1 diastolic dysfunction, impaired relaxation, normal filling pressure, trivial MR, and normal PA pressure, does this patient currently have a left ventricular systolic dysfunction? So who would say yes, he does? Who thinks this guy has LV systolic dysfunction? Who thinks he doesn't have systolic dysfunction? Two people. Who isn't sure? A few people. Well, we talked about myocardial mechanics. So basically the LV, you have longitudinal, you have rotational, and then you have the difference in rotational axis between the base and the apex, which is twist. So it's like wringing a towel, LV function. Twist, untwist. So you have an LV shortening, you have a differential radial rotation between the base and apex, and twist and untwist. So by these vectors, we're allowed to measure the strain. Remember I told you his longitudinal, circumferential, and area strain were all depressed. His systolic strains were all depressed. His severe LVH. So we have very good measures of left ventricular systolic dysfunction in this gentleman with his severely hypertrophied ventricle, even though he has a preserved ejection fraction. And there's a large body of literature showing that tissue Doppler imaging in systole and systolic strain imaging can show regional and global systolic abnormalities in patients with cardiac disease but a preserved ejection fraction. The most common things you'll encounter in clinical practice are chronic hypertensive heart disease, hypertrophic cardiomyopathy, infiltrated heart disease, and we are clinically using strain in our cardiac center, the Juravinski Cancer Center, to serially follow patients who are generally youngish, undergoing chemotherapy, and if they have a certain drop in strain, yet normal ejection fraction, we have a discussion with the oncologist as to where they want to go with the chemotherapy. So the take-home message is tissue Doppler and strain imaging can give you very valuable information on systolic function that LV ejection fraction is too insensitive to measure. Okay, so with that, I'm going to thank you for your time today, and if there are any questions, I think the take-home message is that echo is recommended as the first-line non-invasive imaging modality for patients with known and suspected heart failure. Two-dimensional variables and Doppler variables are used in concert to come up with a comprehensive assessment of LV structure, function, and left and right-sided filling pressures, and can be used to estimate prognosis in patients with heart failure. Thank you very much.
Okay, thank you, Dr. Hisham, for this very nice, informative presentation. And if you have any question for Dr. Hisham,
any questions from the audience on anything? I'm sure there are a lot of variables or things I brought up. Yes, sir.
Regarding RV function, how much do you rely on RVS waivers or tissue Doppler as a measure of RV function?
So let me put it this way. The recommendation from the American Society of Echo, they put out their right ventricular guidelines in 2011, suggests that some quantitation of RV function must be done. Tricuspid annular plane systolic excursion, or TAPSE, is the up and down difference in location of the tricuspid annulus through the cardiac cycle. Greater than 1.7 is normal. That's recommended. Tissue Doppler is the velocity of the longitudinal motion. The problem with these measures is it's just one axis of the heart. You can have RV dysfunction but have a normal TAPSE or systolic velocity or an RV S prime, tissue Doppler RV. So we tend to do both TAPSE, tissue Doppler, and fractional area change of the right atrium. So fractional area change is a difference in RV diastolic area, RV systolic area divided by the LV diastolic area. So it's an area fraction change, if you will, of the RV. Greater than 35% is normal. So we use those three variables plus visual assessment to come up with a right ventricular assessment. So as with diastolic dysfunction, it's a multi-parameter assessment that's going to give you the most accurate interpretation. Any other? Yes, ma'am.
Do these patients with grade 1 diastolic dysfunction have heart failure? They have
Right.
symptoms of shortness.
Right.
Then they have front heart failure.
Yeah.
Would LASIK be?
Yeah. Wonderful question. Fantastic question. It depends. If your peak E wave velocity is less than 50 centimeters per second and your A wave is high, at that instantaneous moment in time, your LA pressure is exceedingly likely to be normal. So I would say, A, make sure that your assessment of symptoms is at the same time as your Doppler acquisition. It's not 3 days ago when they could have been in heart failure. Okay, and B, make sure there's nothing else causing their shortness of breath. There are a lot of little old ladies running around Hamilton, Ontario, Canada, who have grade 1 diastolic dysfunction, who have LV hypertrophy, who are short of breath, but have no other symptoms or signs of heart failure. They may have COPD, pulmonary fibrosis, whatever it is. So I think so the answer to you is, if your instantaneous Doppler assessment is at the time that they have dyspnea, and they have grade 1 and the E wave is low, then it's unlikely, highly unlikely, that they're in heart failure. However, if I take that person to the Chinese buffet and we do 3 laps and we ingest 500 grams of sodium, okay, and I chase that with a lot of water, that little old lady with a preserved EF and a small hypertrophy ventricle can easily switch to pseudonormal filling or even restrictive filling very quickly. It's dynamic, highly preload dependent, so you have to be aware of those issues. So to answer your question, someone with grade 1 diastolic dysfunction can be prone to diastolic heart failure, or they could have depressed EF as well, but at that instant in time, it's unlikely that dyspnea is due to LA hypertension. Well, it depends what the cause is. You have to figure out if they have another cause of dyspnea would be my recommendation. Yeah, I probably would not go up on their diuretics if they're truly grade 1. Any other questions? There's a really good question. Sir Megdi.
Lovely talk, Hisham. My question relates to the twist function
Yes.
of the left ventricle. How much importance do you attach to that? Do you measure it routinely and quantify it?
That's a brilliant question. So there's very good work done by basically one of my mentors, Sharif Naga, in the twist untwist of the ventricle. And I think for simplicity's sake, what we know, so when I said the end ventricle twist, in a normal ejection fraction, the diastolic untwisting seems to be, as well as the longitudinal relaxation, fundamentally important and correlated with filling pressures in a patient with preserved EF. So I would say if someone has preserved EF, the diastolic untwist rate, the more depressed it is, the more likely that person is a candidate for diastolic heart failure. We do not clinically, routinely measure twist untwist. We do it only in research, but we routinely clinically measure global longitudinal strain, which is easily done, and then we look also at the diastolic strain. So what I would do is this. We commonly get this question. 40-year-old patient, 30-year-old patient, family history of hypertrophic cardiomyopathy, very strong family history. Is this patient genotypically possibly positive but phenotypically negative? So we do an assessment with the echo, we measure the tissue Doppler, we measure if the strain systolic and diastolic is plumb normal, it is unlikely, not impossible, that they have a subclinical variant of HCM. And I'm not an HCM expert, Dr. McKenna. So if you have questions on the genetics, please refer to Professor McKenna. But this is a simplistic echocardiographer's understanding of how it can be incorporated. So clinically, yes, global longitudinal strain. Twist untwist is still a research modality, but untwist seems to be fundamental to LV filling, especially in preserved EF. Any other questions? Yes, sir.
Sorry, just on the twisting actually hypothesis. As you said, when the left ventricle contracts, the angle or the direction of twisting is opposite if you go from the vein or if you go from the apex, right?
Right.
So the vectors of movement of the layers at one point in the left ventricle will equal 0.
Yeah,
right?
yeah.
So when you do your measurements, it's really crucial to know where you put your section. Because if you put your section close to the apex and you move downward, your values will go down. At one point, your values will go back up, absolute value.
Great,
So,
perfect
how
comment.
do you pick the exact layer or the level when you are measuring your twisting?
Excellent question. I mean, it's not even a question, it's more like a statement, which is a true statement. Clearly, so by convention, we take basal rotation at the level of the mitral annulus and compare it to the true apical rotation. That is what we do. We do not look at it any other level, but certainly there will be, if there's twist, there's going to be, if you will, a nadir of twist somewhere in the midsection of the ventricle. But by rotation, we use mitral annular level to true apex, and that can be best discerned on a 3D echo, because true apex can be tricky sometimes in 2D echo if you're off angle. But it's mitral annular to true apex, difference in degrees is twist, and the change in degrees over time is twist rate. Okay, thank you very much.
Thank you, Dr. Hisham.